They asked, what would you say if the doctor tells you it's osteoarthritis and there is nothing you can do about it? I would say, go find another doctor. Welcome back to Past Your Prime, the podcast for active adults balancing life, training, and rehab. I'm Alex Keicher, pro-volleyball player, dad, and a guy who currently wakes up with about 3 different check engine lights flashing on my internal dashboard every morning. Today, we are answering an absolute goldmine of a viewer question. They asked, what would you say if the doctor tells you it's osteoarthritis and there is nothing you can do about it? I would say, go find another doctor. Or potentially go to smithperformancecenter.com and speak with one of Craig and his associates. Why? Because hearing there's nothing you can do is an absolute death sentence for any active adult. It makes you feel like your joints are made of wet cardboard and you're destined for the rocking chair. But your MRI or X-ray report is just a snapshot of normal structural wear and tear. It's definitely not a reason to stop moving, and it doesn't mean your joint is broken. As always, I'm here with Craig Smith, PT strength coach. Today, we're breaking down why osteoarthritis diagnosis is not the end of your athletic life, why motion is actually lotion for a grumpy joint, and how to build a fortress of muscle around that tissue so you can keep up with your day-to-day life and activity.
Great intro.
Great
intro. Wow.
Yeah.
Wet cardboard.
You can just visualize wet cardboard just ripping apart. Just think of your knees just ripping apart. And then, your doctor saying, there's nothing you can do.
Yikes.
It's a death sentence.
Okay. All right. I kind of got distracted on that one.
What is osteoarthritis? I was even wrong earlier, and I thought it was just bone loss.
Well, so osteoarthritis, what I think is interesting, it's a more complicated condition. It's also one of them where I don't feel that the way people get diagnosed is always consistent. There's a grading scale around it with imaging. There's also typically supposed to be exam findings and subjective findings that should be matching it before somebody's diagnosed. But here I went and found on the most comprehensive definition I could find from the Osteoarthritis Research Society International.
Unbiased.
It's not unbiased at all. Yeah. So osteoarthritis is a disorder involving movable joints characterized by cell stress and extracellular matrix degradation initiated by micro and macro injury that activates maladaptive repair responses, including pro-inflammatory pathways of innate immunity. The disease manifests first as a molecular derangement, abnormal joint tissue metabolism, followed by anatomic and physiological derangements characterized by cartilage degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function that can culminate in illness.
You're going to have to dumb that down for us quite a bit, sir.
Well, so it's basically a change in, we all have joints that can move in our body, right? And so where those 2 bones meet, that's a joint, right? And they have surfaces that become degraded from a variety of reasons. And depending on what research you read, there's different opinions on what's happening. What I think is happening is you're having mechanical overload to a joint for a variety of reasons. It causes inflammation possibly to develop, even though there's pretty solid evidence that there's not always inflammatory issues happening in an arthritic joint. And then over time, it can progress to the point where you can't really use the joint.
And it's also potentially not even painful.
100%, yeah. You can have there's large amounts of people who won't have pain with osteoarthritis.
Yeah. And I guess that kind of doubles down on imaging doesn't always equal pain.
Well, yeah. It's kind of, I think it's a really interesting issue. And it's one of them that really, especially when I was a new clinician, that was really surprising how often I'd have people come in where they had they had basically found arthritis in a joint when something else was being imaged. And they're like, oh, look at this. Look at it. Like say something's wrong with their back, and they get their back image, and all of a sudden on the one side, their hip is very arthritic and they have no hip pain. Things like that, where you're like, oh, why do I have this? And then, is it just, it's been brewing for a while and you're just waiting to feel pain? That's something we can talk about today. But it seems to be one of those things that's not, it's definitely not uncommon to have osteoarthritis with no pain.
Well, there's nothing you can do about it anyway. So
not to,
the doctor said.
Well, not to throw the guy under the bus. I guess I would strongly say I don't agree with that thought process. But I do think I understand where he's coming from. So the way I look at it, there's 4 things that you may be looking for. If somebody comes in and they say they have osteoarthritis, and say it's a component of their pain generator, like it's what's causing the pain, there's 4 things I think you can absolutely do. Or there's 4 hopes that you can have. And I think the first one is symptom reversal. Like you can make the pain go away. I 100% think you can do that with osteoarthritis. And we'll talk about how, I guess, at the end today.
Sure.
You can take away the functional overload that's happening to the joint. In some cases, sometimes there's abnormalities to joint that's gone so far, call it like past the point of return, where you can't reduce it. And at those points, I would totally agree. There's surgical remedies that have to be done in those situations, but vast majority that's not the case. Inflammation or tissue irritability, I think you can reverse that as well. And then the final one, which I think is probably what the doctor was talking about, not the first 3, but the last one, is that the structure itself, can we reverse the changes that you're seeing on the image? I don't think there's good evidence for that. But to be honest, I don't think that we've set up the appropriate things for people who have this type of problem developing to create an environment for the joint to heal over a long period of time. Because I do think it takes long-term management.
I was going to say the long-term part of that is probably the most prevalent, because these are degenerative diseases or pathologies, whatever you want to call it, and those take a long time to develop. And I think it's going to take an equally, if not a longer time to fix them, if it can in fact be fixed.
Why? And I don't see why that one tissue it'd be the only tissue that can't heal. I have a hard time believing that. I think that so you have a pathology that develops in the joint and it causes abnormal pathomechanics. So the joint now starts to get mechanically overloaded, and wherever that spot is, you get overpressure from every time for example, the most common places where you're going to get osteoarthritis: knee joint, hip joint, your hands. Like those are probably like the 3 most common places I see it. Sometimes people will come in and they'll have it in their spine, on their facets.
Maybe their hip.
The hip is a really common one. I would say I would say the knee and the hip are
knee, hip, and hands
by far the most common, which I always kind of think is interesting, because I think it's where there's a lack of congruency between the joint surfaces, which I think you see in some ways. Like the people who get it in the hip, for example, they often have a shape of their femoral head that's different than it doesn't go well into the socket. And those people, especially with congenital abnormalities, like the way they were born, those people are typically, it's hard to get in front of those types of situations.
That's that 4th structural category you were talking about.
Yeah. Like you're not going to change that.
Not necessarily impossible through surgery to fix, but aside from that, there's not really a whole lot you can do.
Well, it's on a pathway that's going to go down, but then there are absolutely things you can do to minimize it. It's just realizing you got dealt a bad genetic hand. It's like,
you didn't hit blackjack.
Yeah, you did not hit blackjack. You may have gotten a 16 on that one.
Got a 16 going up against a queen. It's not looking good.
You have to still hit though. Like that's like if you're one of those people who stay at that point, my God, you drive everyone crazy at the table.
But the guy next to you has an 11 and you're hitting the 16, and obviously
you got the 10. Everyone hates you now. This isn't quite that bad as that situation. No, but I mean, even in a situation, the state of the joint, there's other things that absorb force besides the joint surfaces. And I think that's one of the pieces that I think about a lot is, are we maxing out everything in your system to be able to mechanically handle force? And if not, then you're leaving a ton on the table. But there's so many tools that we can use to help somebody who has symptomatic osteoarthritis to make it so that they can still do every activity they want to. But it has to be very specific to how you're presenting. But we have a general outline that we'll go over today. But just from the root cause, to answer your question, K.E. Mac out. I love the name. Yeah, I think that the biggest issue that your information that you're getting is he's probably describing it. He or she, the physician, is describing it as the structural reversal. I don't disagree that at this point there's not good evidence that we can reverse it. But symptom reversal, 100%. Functional reversal, 100%, and then inflammation reversal, 100%. We absolutely can.
Which all leads to like pain reversal, basically.
Yeah, and I think that kind of leads us to the idea of tissue capacity, right? The idea of tissue capacity is it's not just what mechanically the tissue can handle, it's the threat detector. And that's why any information that you read on it, that's why there's not that strong of agreement between imaging and pain and ratings of disability with people who have the diagnosis of osteoarthritis.
Yeah.
You know what I mean?
Well, and we had talked about it earlier, but from that, from that standpoint, I liked the term tissue tolerance, even compared to tissue capacity, just because it's like, what can the tissue handle? I just feel like tissue tolerance and like kind of that threshold for pain in terms of the tolerance that you can withstand. Are you in, a 10 out of 10 pain tolerance, or are you in a 1 out of 10? You're going to be able to tolerate that one way better than the 10.
I think it's good that you bring that up because there is a difference between threshold for pain.
Yeah.
There's a difference between what you can tolerate before you say uncle. And I think that's important for us to remember. That's all part of the pain system. And so your threat detector or your pain system, however you want to think about it, that is not the same thing as what your tissue mechanically can handle. And you can get those really thrown off. They don't always stay in relationship with each other. And so somebody can come in and be in absolute agony and have a completely normal radiograph. Like they could have a completely negative exam and they still are experiencing real pain. It's not that it's fake. And the next patient that I have could literally have the worst imaging come in where they say it's bone on bone. I've been told that I'm going to have a total knee, and they have a normal exam.
And can function as much as they want to.
Yeah, and so those people have a fantastic outcome because now all I have to do is I have to reverse some of their symptoms. Typically, they've have not just, typically that means that the joint, the thing that's arthritic is actually not their pain generator. Typically, it's something else that's unrelated. It can be a patellar tendinopathy. It could be that they have something that's referring to the area. It could also be something as simple as like they have an incredibly stressful life and something's triggered it and they're really nervous about their knee, and that's the place where they're experiencing symptoms. There can be a variety of different reasons. Those need to be addressed. That's very different than me changing the structure. Like that's not the point of anything that a PT does, but we try to create a situation where the tissue capacity increases. And I would say how you're thinking of a tissue tolerance, like what the mechanically can handle, I like the term as well. I think it's very different than the pain system. And I think understanding that those two things are very different is important.
Okay.
Yeah.
Let's get into a little bit more. The first thing is kind of a big, maybe myth, maybe it's not a myth, but exercise and heavy lifting, wearing down a joint, if somebody already has mild arthritis, or does it do the opposite in terms of actually building things up? I tend to think that you want to load joints. That helps with the healing process, but what does Craig the PT Smith say?
What do I say? Well, I think it's kind of going back to the root. Do you have a diagnosis? And so if something does hurt when you're loading it, I would not load it heavier. I don't think that makes sense, especially if we think it's the joint that's causing the symptoms. But this kind of goes back to if it's a tendinopathy, yeah, I'm okay with there being a little bit of pain. But
does the heavy lifting cause the arthritis? Say you've gone in with, we've got our viewer question here.
Yeah.
And, maybe the doctor says like, oh, this is because you've been, trying to squat heavy weights. Like,
I think is
there a correlation there?
I don't think so. I think what they're going off of is there is evidence that osteoarthritis so it's more common in women, unfortunately. It's more common in people who are heavier. I don't think that there's really any strong evidence that it's around that type of physical activity. It's typically more in people who've had a primary injury to the knee joint or the hip joint, whatever joint's involved, and that there's some occupational relationship to the joint being overloaded. Those are going to be like your strongest risk factors. That the whole idea that heavy lifting or running, I don't agree with that whatsoever.
Yeah.
But if you have an injury, for example, that developed in the knee, like so say you had meniscal damage and somebody did a meniscectomy on your knee, and now every time that you lift heavy, your knee joint gets bigger, it swells up. Yeah, you're overloading the joint. You're progressing the degeneration of your joint.
Okay, so it's kind of not either end of that spectrum. It's
Nuanced.
not necessarily contributing to your arthritis, but it potentially could make it worse. So it's not the greatest thing you can do either.
But it's also why would heavy loading help? Well, heavy loading could help if you're really targeting and moving it through your muscles, and now your muscles allow you to take on the actual primary things that overload your joint. So say, for example, the thing that's actually hurting you is your walking gait. And because you get your quad stronger with lifting, those quads can now handle that walking pattern much better. Yeah, you're in a much better place. But instead of, let's say, every time you load your knee joint with a squat, you make it feel dramatically worse, you're making it worse. Yeah, you're progressing. You might be progressing the joint degeneration.
Okay.
Mm-hmm.
So let's say you've got, whether it's knee or hip arthritis and it feels angry after a workout. What does that look like? Is there like a traffic light system?
Way to look at
stop or proceed with caution, or just like.
And we're talking about if somebody has actually been diagnosed with osteoarthritis.
Yeah.
And we're talking about the knee joint specifically.
Yeah. And, they're trying to stay physically active. But, how do they know if they did too much or if, it got inflamed just as a part of the healing process and it's okay to proceed?
I think that there's 3 really easy key signs. Well, we'll say 4. So first off, you should not hurt after you exercise. So there shouldn't be an increase in pain. You shouldn't feel an increase in stiffness. So any mechanical changes that are different in that joint than the opposite joint, like the other knee, that's something to be concerned about. They should feel similar. So that'd be like the number one. Like just look to see if you have a side-to-side difference, especially pain. But then you should be able to check. You can do what's called a brush and sweep test to see if there's swelling now inside the joint. That would be my next favorite. Any loss of motion. So if you now can't fully extend your knee and you can't fully flex your knee without almost a feeling of stickiness, or it kind of feels gross and limited, that's a bad sign. That typically indicates that you did something to inflame or irritate the joint, and now the synovial lining around your joint is pissed,
angry,
not tolerating any type of tension. So we don't want that.
So if that listener is listening right now and they're terrified to move because of this doctor's warning, what are some kind of high yield things they can do in the gym to start changing their environment around the joint? What is the physical therapist prescribing?
The thought process.
Yeah.
Well, I think the number one thing would be confirming the diagnosis. So I feel like the biggest part when somebody comes in with the diagnosis of osteoarthritis, the vast majority of those individuals have been diagnosed almost exclusively via an image, an x-ray. And so I don't think that's sufficient.
If it's the knee, I don't even know what kind of doctor would.
It could be general. It could be ortho.
Yeah.
Non-surgical ortho, or just surgical ortho.
Do you think that they're doing kind of the same sort of knee exam that you would be doing?
No, I think it's slightly different. I think that each person brings a little bit of a different practice pattern, and a different bias, which I think can all be very valuable.
Yeah.
The people who don't go down a surgical route, because of how their practice is constrained, they'll look at it slightly different, which I think is actually very valuable. So when somebody comes in and they have, if it's a surgeon and they say that there's nothing we can do right now, they may be saying that because there's nothing in their wheelhouse that they can do, because their treatments might be a cortisone injection or a surgery, right? So if those are your 2 tools and one of them is no longer working, which is pretty common, because I don't think that everybody that has osteoarthritis, it's not always inflammation that's causing their pain. Oftentimes it can be the joint overload, right? And especially when you get to a point where like we talked about 2 episodes ago, where you get into this doom loop of basically continuing to hammer it, and all of a sudden now the injection is no longer working. That tells you that inflammation is not the main pain generator at this point. So you knocking out inflammation is no longer a serviceable treatment. And okay, so that means that those pathways of treatment are now gone. So if we're still going for the 3 things, symptom reversal, functional improvement, and reduction in inflammation, we have to go for the first 2. And so for symptom reversal, we got to make sure there's no other pain generators. And oftentimes what I find with osteoarthritis is there's always more than one thing that's probably contributing to the pain.
So you kind of have to look at the whole day, the person's whole life, and what other contributing factors they'll have.
I think that's a big one, but you have to see if there's other actual causes of pain. So MCL, patellar tendon, is there a meniscal component? Is it the quad tendon? Is it the actual patellofemoral joint, or is it medial lateral joint compartment that's causing primary pain?
Do you see that in osteoarthritis diagnosis a lot, where there is another contributing, call it
pain generator,
or tissue that's contributing to it?
I would actually say that that's oftentimes one of the more common issues, is that you have more than one thing that's actually contributing to symptoms.
Interesting.
But it makes sense at the same time. Like, so if you think about the knee joint, I think is always just the easiest one, but we can say the same thing for the hip joint. If it's not handling load, your body's going to try to help, and one of the ways it does it is it can create abnormal movement patterns, get co-contractions of muscles, or it actively tries to avoid loading in a way that hurts it in that moment. So you get these really goofy walking patterns, these really weird loading patterns with basic movements like a hinge or a squat, which everyone does on a day-to-day basis. And they do it in a way that try to unload it. And oftentimes that can actually make it feel worse or progress a degeneration to the point where you can't get out of the doom loop.
Or you're compensating, right? And so another part of your body is going to take on that load, and then for depending on how long you're making that compensation, you're going to end up with something else hurt.
Well, it's kind of like, you remember when we talked about layered pathologies?
Oh yeah, layered pathologies. It's the probably same thing. 30 episodes ago.
Well, it's the same thing. Yeah. So layered pathology, it's fascinating how often people will come in, they'll have a primary thing that's hurting them, and as soon as we pull that away, then the thing that was compensating for now becomes painful. And then once that goes away, now another thing comes out, and it's like you're pulling back all of these layers of compensation that resulted in overload and injury.
Yeah.
I think these are really common, especially if it's really common when somebody has, in my opinion, a primary injury that happened whenever, and it caused the joint to now be able to not be able to handle the compressive forces going through it with every step. And then from there, over time, they've probably tried to unload it, but you still had this disease progression happening that they weren't aware of. So that's why, like, number one, get the diagnosis. Make sure that there's nothing else that's actually causing symptoms. After you get that, then it's all about developing a therapeutic gap, and that's number one to get symptom reversal. So if you don't develop a therapeutic gap, I agree, it's not going to feel better. But a therapeutic gap basically just means you know what your triggers are. You get a really clear trigger list, like what things are making you feel worse. And then on the other side, what treatments can you do to make it feel better? And remember, with treatments, the idea is it's not just pain relief. It actually makes the tissue capacity better, meaning that it can handle more mechanical load in the future without throwing off your threat detector. So like those 2 things can sometimes be hard, and that can be the tricky piece, because people will do things like aggressively stretch a joint that may feel better in the moment, but you actually piss the whole system off.
That's made it worse.
Yeah, that's actually a trigger. So you want to make sure you don't have a false therapeutic inside your treatment regimen.
I mean, I know we've talked knee, hip, hands are the major ones, but like for any of those, what are some examples of things that are opening up that therapeutic gap?
Let's kind of run down. So
like traction, I'd assume, is one.
Traction is just the easiest one because it doesn't put us in a compromised position where you are going to hurt anything. That's why I always think traction is like a really nice, simple one. You can grade how hard you pull, so it doesn't feel that intense. It can be light activity that's like my favorite one if everything is sensitized. Really light, really well tolerated activity. Those are really nice.
Because I feel like a lot of people with knee and hip, like just walking sometimes can be one of the biggest triggers and the most painful. So like a bike, maybe even an elliptical or something where you're not actually pounding the ground.
Because remember, load it's way more than what you think. So when you're walking, it can be 10 to 30% more than your body weight going through your leg. And so if you're every time you take a step, if you're getting 100 pounds, you're getting 110 to 130 pounds going through your leg every time that you walk, right? That's so much more than what you think it is and what you think it is. So if you're hurting and you're squatting 45 pounds, you're getting more than that every time you take every time that you take a step, because you actually split it between both legs. So if you're squatting your body weight plus 45 pounds, you weigh 100 pounds, that's at most, what's that, 95 pounds?
Yeah.
And then if you literally go walking, you're getting over 100 pounds every time you take a step. So you don't realize walking is actually a significant load. And then the big thing with walking, for example, we talk about knee, the reason it's such a big trigger is most people mess up multiple points of walking gait once the joints become irritated. So you'll do things like an abnormal initial contact. So when your heel first hits the ground, you won't have your knee fully extended. So you won't be able to set up the quad to be able to load, because the knee needs to bend 20 degrees from the time your heel hits the ground, your heel hits to where your foot goes flat. You have to have 20 degrees of flexion, which sets up your quad to load it. Most people who have a knee issue, especially if they have early onset OA, when they hit, their knee stays totally in extension, and they stay in extension the whole way to where they're into mid stance. And that means you only get it through the joint. You're only loading through the joint. That's a bad thing. And so you want to go through and you want to pull out all the triggers, and you want to understand that things that seem easy, because they are easy, because your physical capacity is much higher, could actually be still dramatically too much for your tissue capacity. And that can take a lot of time to figure out your trigger list.
Well, and I mean, people need to walk, so I know that maybe changing your gait is probably not as easily said as done.
But you can do things for that. Like, right. So for example, you can use a single point cane on the opposite hand. It's going to reduce some of the knee adduction moments that happen. It can reduce the overload that happens at initial contact. They can set your leg up so that you feel more comfortable loading it, because people will feel like you avoid muscles that your body doesn't trust.
Yeah.
So when people feel tightness somewhere, that's not because that muscle's weak. It's because that muscle's being overused, which is typically opposite of what most people think when they first feel something firing too hard. And that's an important one to remember. And so finding if it's something you have to do, then you get an artificial stabilization tool to unload the joint until you build tissue capacity up to where that's no longer a trigger and overloading your tissue capacity.
What are the other artificial capacities that you use here?
For knee?
Knee or
for any of them? The most common one, I mean, yeah, I really like ones that basically set up a situation where the joint is no longer overloaded when you use that joint. So the easiest one for the knee is called the surf strap, which unfortunately they have quit making these. So we use a modified ACE wrap technique where you literally use an ACE wrap to wrap around your knee, and it reproduces what your glute max does. So it externally rotates your leg, abducts, and helps with basically the mechanics of your femur on your tibia, which will help to unload and create a healthier joint mechanics for people. Does that for the hip as well. We'll do things like the cane. Those are pretty obvious ones. If you can't get full knee extension, we'll do things like a heel lift. So basically, if your joint doesn't handle full motion, you want to avoid those full motion events. So for example, every time you take a step, you have 2 times where you go into complete knee extension. And if you go into complete knee extension both times, you're now traumatize the joint with, 10%, 110% of your body weight to 130% of your body weight every single time. And that's just important to remember. So if you don't take out those events, you're basically hammering yourself over and over again. And if you don't manage triggers, it can easily overwhelm any treatment that you do. And that's just important to remember. But from there, after you have a therapeutic gap at least started, then you have to get a key sign to give you information on the state of your body. Because if you don't, it can be really, really easy to constantly overload. I mean, you have that problem, and you're actually really aware of your body despite using terms to help confuse yourself.
Yeah. I mean, I don't know. I'm just not good at listening to any of yours or my own advice.
Well, how do you, but that's quite crazy. But if you had a diagnosis of osteoarthritis in your knee, and you knew that the issue is not now, it's that you have to basically manage this, or you're going to get a total knee, would you be willing to monitor the state of the joint?
Probably more so than I currently do. Yeah.
Yeah. Is it partially, I think part of the reason that you don't do it is you've had success just kind of pushing through, right?
Yeah.
But I think with this type of a diagnosis, I wouldn't
There's
push
not
through.
just an easy push through. Yeah.
I think it has to be managed. And I think it's a very different thought process. And that's why I don't quite trust, once again, I know that there's no good research that shows structural reversal is possible that you can take away. I'm not saying that, but I also don't think that there's been good management systems that have been out there. But there's like really cool research that shows people who've been told that they have to get a total knee, if they're able to get full knee extension and maintain full knee extension, the rate of them actually having to get surgery drops dramatically. And that's just one variable. That's just knee extension. That's not looking at knee flexion, joint swelling, quad strength, glute max strength, glute med strength, the way you walk, the way you squat. If you knock all those out, your knee is going to be in a really good place, and I won't care what the imaging shows. You know?
Yeah. Imaging does not always equal pain and or function.
No. I just think it's like bone on bone. The idea is that it's always getting overloaded. Sometimes that's the case. Like you can't get in front of.
But there's also been people that have played in the NBA at that level that have been bone on bone and still been able to do it. They probably had some pain.
Oh my God.
I'm not saying, but the ability to function
that
can still be there.
I do think that that's kind of one of the places where you can talk about silliness that happens with training, the overload that they'll do when somebody clearly has an issue. I don't think their management strategies always quite make sense when you watch what they're doing, but if you think about it, you can be incredibly active with a diagnosis of osteoarthritis, incredibly active. Getting back to a point where you can do that though can take a lot of work.
Well, hopefully that gives our viewer a little bit of hope for the future. And definitely feel free to consult with Craig or one of his colleagues if you have more questions.
Can I say one more thing?
I was going to say no, but I guess so.
One more thing is just remember that you want to monitor it forever. So once you have that, then the idea is it's a permanent monitor, in my opinion, which means that's a very
like
different,
a death sentence.
It's not a death sentence. It's more like that you just remember that if osteoarthritis can be present without pain, pain can't be the thing that causes you to get it checked out. You need to have something that's checking it all the time and have like really clear variables that you're looking for to see that the joint is still healthy. And it has to be separate from when it hurts, which means you have to get it checked out more regularly, or you need to be able to check it out. And then and by check it out, I mean, I'm not saying progressive x-rays. I'm saying know what is a sign of that joint handling load well. And if you don't know, that's what a surveillance system is for. So that's what we would help set up for you.
Yeah, we would attach a camera to your quad that watches your knee.
That does sound creepy, doesn't it?
We will surveil your knee constantly until forever.
Yeah, injury surveillance. It does make it sound like we're creepy people walking around.
And you're wearing like an investigator hat today.
Oh yeah,
yeah.
I mean, with the investigator hat, it makes it so it's easier to blend in and watch people. Are you
you're just watching their knees?
I'm just I mean, that also makes it sound really weird too. Everybody's like, "What are you doing?"
Yeah.
I'm watching. Do you ever go to the mall just to watch people walk?
Just to watch people's knees?
Yeah.
Yeah.
Never.
Those benches are at a good height for that.
Oh yeah.
I can't remember the last time I've been to a mall.
Oh, can you imagine? I mean, how quickly you get arrested?
I don't think there's anybody there.
No, it's pretty busy, but it's
really?
like,
oh, okay.
I have no idea.
Yeah.
No, I'm not a shopper.
Me either, I guess.
I went off the rails.
Alrighty.
If you are enjoying this podcast and finding the information useful, please consider supporting us by following the show on Spotify, Apple Podcasts, or wherever you listen.
By subscribing, you help ensure we can continue bringing you this high-level training and rehab science every single week. Leaving us a 5-star review on those platforms is also one of the absolute best zero-cost ways to support our mission and help grow this community. Our podcast is proudly sponsored and brought to you by Smith Performance Center. If you are an active adult looking to bridge the gap between rehab and elite performance, or if you want to optimize your health from every angle, go to smithperformancecenter.com. They offer elite physical therapy, strength and sports training, and dedicated nutrition coaching to help you build a resilient body that handles the activities you love without breaking down.
If you want to connect with us, see our training clips, or watch the full video versions of these episodes, follow us on Instagram at Spiker Keicher, Craig Smith PT, and Past Your Prime Podcast. And subscribe to the Past Your Prime Podcast on YouTube.
Thanks for tuning in, and remember, you're not past your prime, you're just getting started.
PYP, baby.
Peace.
Was I loud?
Yeah, louder than usual, yeah.
Is
very close.
Is it too close now?
Yeah, it's fine.
It's fine. Suck my balls, Alex.
That's going to be like that
That's
last
always
clip is going to be suck my balls, Alex. Yeah, just, that whole reading. And at the end, you need to say PYP, baby.
Oh.
At the very end of it. I tried to do this and you're just like, I'll just fuck off. 1, 2, 3. I clapped.
Is that going to be loud enough? The way he did his hands?
1, 2, 3. 4.
He's now have no idea where to start it.
Should we start now?
Yes.
He's annoyed.